Hello and welcome everyone. Today we are discussing about gout. In this video we are going to discuss about stages of gout, pathophysiology, diagnosis and management of gout. Gout is a most common cause of chronic inflammatory arthritis. It is a systemic disease that results from deposition of monosodium urate crystals (MSU) in tissues. Increased serum uric acid level above specific threshold is a requirement for formation of uric acid crystals. Despite the fact that hyperuricemia is a main pathogenic defect in gout, many people with hyperuricemia do not develop gout or even form uric acid crystals. In fact, only 5% of people with hyperuricemia above 9 mg per dl develop gout. The stages of gout: acute gout flare, chronic gouty arthropathy, accumulation of urate crystal in form of tophaceous deposits, uric acid nephrolithiasis, chronic nephropathy. Acute flare. This is the initial manifestation of gout. It is characterized by abrupt onset of severe pain and swelling. The maximum inflammation occurs within 12 to 24 hours. The gout flare is typically monoarticular, often occurring in the lower extremities. The most commonly involved joint is a first metatarsopharyngeal joint. The initial attacks resolve within 3 to 14 days, even in the absence of pharmacotherapy, but the subsequent attacks are prolonged. The gout flares are more common at night and in the early morning when cortisol levels are low. The pain is often sudden, waking the patient from the sleep, or may have developed gradually over a few hours before presentation, with maximum intensity of pain at 24 hours. The pain is usually severe and not responsive to usual home remedies. Even touching the patient can be excruciatingly painful. Gout flare-ups often incite local inflammation, which present as erythematous, swollen, and warm joint. The erythema over affected joint during an attack is characteristic of gouty synovitis. Systemic features of joint inflammation may include fever, general malaise, and fatigue. Tophi, which are subcutaneous deposits of urate that form nodules, can also be found in the patient with persistent hyperuricemia. Chronic gout. Chronic tophaceous gout usually develops 10 or more years after an acute attack. Gouty tophies are foreign body granulomas around deposits of MSU crystals. They appear as a chalk-like subcutaneous nodules under transparent skin with increased vascularity. Tophi may be intra-articular, periarticular, or extra-articular, the most common site being the digits of hands and feet, knees, and the olecranon bursa. Now let's learn about pathophysiology. Worldwide, incidence of gout increases gradually due to poor dietary habits such as fast foods, lack of exercises, increased incidence of obesity and metabolic syndrome. Urate is ionized form of uric acid present in the body. Uric acid is a weak acid with pH of 5.8. Urate crystals deposition in the tissues start to occur when serum uric acid level rises above the normal threshold. The pathological threshold of hyperuricemia is defined as 6.8 mg per dl. Some factors may affect the solubility of uric acid in the joint. These include synovial fluid pH, water concentration, electrolyte level, and other synovial components such as proteoglycans and collagen. Serum uric acid level in the body is determined by balance between its production either from purine intake in diet or endogenous production by cellular turnover, and its excretion by kidneys and GIT. Increased production of uric acid is responsible for only 10% of cases of gout, while remaining 90% are caused by its renal underexcretion. Genetic, metabolic, and other factors that results in hyperuricemia and metabolic, physiological, and other characteristics are responsible for MSU crystal formation. Uric acid, the final product of purine metabolism, is a weak acid that circulates as the deprotonated urate anion under physiologic condition that combines with the sodium ions to form MSU crystal. The inflammatory, cellular and innate immune processes and MSU crystals themselves promote the acute inflammatory response. Chronic inflammatory processes and effects of immune cells and crystals on osteoblasts, chondrocytes and osteoclasts contribute to cartilage attrition, bone erosion, joint injury and formation of tophi. Now let's learn about the diagnosis of gout. The first is clinical diagnosis. The clinical picture of gout is divided into four types. First is asymptomatic hyperuricemia. Second is acute gouty arthritis. Third is intercritical period. And fourth is chronic tophaceous gout. Laboratory diagnosis. The gold standard of diagnosis is identification of characteristic MSU crystal in the synovial fluid under polarized light microscopy. MSU crystals are found in synovial fluid in all stages of disease, during attacks, in the intercritical period, or in chronic tophaceous gout also. During an acute attack, WBC count is increased, ESR and CRP are also increased. During an acute gout flare-up, serum uric acid level may be high, normal or low. Diagnosis of gout based on hyperuricemia is a common misconception. Hyperuricemia is helpful in clinical diagnosis of gout in symptomatic patients, but hyperuricemia alone does not definitely confirm the diagnosis. The most accurate time for assessing the serum urate level to establish a baseline value is 2 weeks or more after acute gout flare completely subside. Synovial fluid examination. Monosodium urate crystal identification remains the gold standard for gout diagnosis. The presence of MSU crystal in synovial fluid obtained from affected joints of bursas visualized by direct examination of fluid sample using compensated polarized light microscopy. Synovial fluid during a gout flare-up usually a yellow in color, cloudier in appearance, and it contains crystal and white blood cells with neutrophil predominance. Polarized microscopy. Monosodium urate crystal deposition under polarized light microscopy is typically described as a rod or long needle-shaped crystals with negative birefringence. MSU crystals are known to have a triclinic structure in which stacked sheets of purine rings form needle-shaped crystals that are observed microscopically. Histopathology. Under light microscopy, tophi consists of several zones: the crystalline center, the surrounding corona zone, and then fibrovascular zone. Multinucleated giant cells, histiocytes and plasma cells are present in corona zone. Radiological diagnosis. Imaging modalities include conventional radiology, ultrasonography, conventional CT, dual energy CT, magnetic resonance imaging, nuclear scintigraphy, positron emission tomography are useful in aid in diagnosing gout. Now let's learn about management of gout. The management goal include treatment of acute condition and lowering a serum uric acid level for prevention of further attacks. The management of acute flares aims at decreasing the inflammation and decreasing the pain. The physician should start treatment within first 24 hours of onset to reduce severity and duration of flare-up. The first line treatment for gout flares are non-steroidal anti-inflammatory drugs, colchicine or systemic glucocorticoids. The naproxen or diclofenac is initiated. Aspirin is not used to treat gout flare due to paradoxical effects of salicylic acid on serum urate levels. Glucocorticoids are recommended in gout patients in which NSAIDs and colchicines are contraindicated. These agents are also drugs of choice for patients with renal insufficiency. The initial dose for gout flare is 30 to 40 mg of prednisolone or prednisone once daily or given in the divided twice daily dose until the flare resolution begins. Then they taper the dose of glucocorticoids over next 7 to 10 days. The glucocorticoids can be administered intra-articularly for monoarticular gout flare-up or orally for polyarticular flare-ups. Colchicine is comparably effective to other agents if taken within 24 hours of gout flare onset. The subclinical joint inflammation in gout forms the basis for colchicine prophylaxis. Lowering a serum uric acid levels below deposition threshold either by dietary modification and using serum uric acid lowering drugs is a main goal in management of gout. This results in dissolution of MSU crystals, preventing further attacks. Medicines are xanthine oxidase inhibitors like allopurinol and feboxustat. It works by inhibiting uric acid synthesis. Allopurinol is a recommended first-line drug in gout. Other drugs are uricosuric drugs, uricase, pegloticase. The dietary recommendations include reducing alcohol consumption, limiting purine-rich foods such as meat, seafood, high fructose corn syrup and sweetened soft drinks, and substituting the low fat or non-fat dietary products for their higher fat content counterparts. While food rich in purine of vegetable origin such as beans, lentils, mushrooms, peas, and legumes do not carry any risk on hyperuricemia and gout, thus they can be allowed in gout patients. Food rich in vitamin C, low fat dietary products, plant oils such as olive, sunflower and soy were associated with reduced risk for hyperuricemia and gout. Weight loss and adequate hydration will also help to reduce gout flare-up frequency. These are the references for this video. Hope you like it. Thank you. Bye. See you in the next video.